Good morning. So I have been asked to talk about the newer invasive methods in pulmonology. And we all know that the thoracic diseases can be divided into diseases of the lungs, those involving the airways, the mediastinum, the pleura, metastatic diseases, and vascular diseases. And most of the invasive methods have been built or innovated over years around these. So let's take them case by case. Let's talk about this gentleman who was 32 years old, presented with persistent cough for 2 months, non-specific weight loss and fever twice daily, and no comorbidities. His clinical examination was unremarkable. And on further examination, you could see that he underwent a chest X-ray, which was abnormal, and went on to have a CT scan. And you can see that he has multiple mediastinal lymph nodes at the paratracheal level and also at 4R for paratracheal, lower paratracheal level, and also at the subcarinal level. And when you look at this in the sagittal section, you can see that there is a very large lymph node at the paratracheal level. Now, if you think about what investigation can be done to reach this lymph node, if you were to do a bronchoscopy, then you would have to put in a bronchoscope, which would come into this lumen, but this lumen is not going to show you anything except slight compression outside, because this is extrinsic to the bronchial wall. How can you reach this? A plain bronchoscope is not going to be able to reach this. How about doing a CT guided biopsy? You will have to traverse that much of lung to get to that lymph node, and pretty much this patient is at high risk of developing a pneumothorax. But you really need to diagnose what's going on, because this patient is symptomatic and the lymph node appears quite large. So you look at the differential diagnosis. When you look at this, you are looking at a 32-year-old male. So it could be tuberculosis, it could be sarcoidosis, and it could also be a lymphoma. And therefore, you need a definitive diagnostic modality of choice, not put him through a few tests, but a single test. So what can you do to reach this? This is where an endobronchial ultrasound comes into play. What is an endobronchial ultrasound? If you go back looking at this picture, you can see endobronchial ultrasound is a bronchoscope which has an ultrasound at its head, which can see across the bronchial wall and tell you different textures of vessels and lymph nodes and guide a needle through the bronchial wall to try and get a sample out of it. So we did an endobronchial ultrasound, which showed multiple lymphocytic inflammation interspersed with caseation and epithelioid granuloma, which was in keeping with TB. And follow up, the patient is asymptomatic, a 2 kg weight gain, and completed his treatment. So a little bit about endobronchial ultrasound. It uses the ultrasound imaging capacity, which depends on the capacity of tissues with different impedance according to variations in transmission, absorption, and reflection of the waves back to create images. It was originally developed for mediastinal staging of lung cancer, and that practically did away with mediastinoscopy, which is a far more invasive procedure. This is a minimally invasive procedure done in an outpatient basis under conscious sedation rather than general anesthesia, putting in a scope through here in mediastinoscopy and keeping the patient in hospital. In EBUS, practically you do it as an outpatient. Patient does not need to stay at home. And it was gradually developed to look at intrapulmonary tumors, which are transbronchial tumors, unknown hilar or mediastinal lymphadenopathies, and mediastinal tumors. So the principles are based on a piezoelectric crystal with a standard frequency of that being 20 megahertz for a radial probe. The radial probes are tinier, thinner, and can travel a longer distance to look at peripheral transbronchial lesions, and a larger 7.5 megahertz convex probe, which is usually used for looking at mediastinal lesions. And this is what is more commonly used. As you can see, this is your bronchoscopic image, and this is your CT. And when you look at the EBUS image, it will look something like this. So this is the carina. As you can see, at the carina, there is a lymph node. Just below this is the left atrium. The node above the left atrium is your station 7 or carinal lymph node. Through this, there is a 22 gauge needle sheath, internal sheath, which is passed. The image is processed. Lesions can not only be seen, they can be measured, and Doppler mode used to look at the vascularity around it. So this is your radial probe, and this is your convex probe sheath coming out, and there's a balloon that you can use. Many people do not use a balloon once they get trained and accustomed to use it. And staging lung cancer, viewing mediastinal structures, guiding transbronchial needle aspiration, and guiding transbronchial lung biopsy in peripheral lesions are some of the uses of endobronchial ultrasound. This is the lymph node station each of you should be aware of. So with endobronchial ultrasound, especially with the convex probe endobronchial ultrasound, all the mediastinal lymph nodes are accessible except the paraesophageal lymph node as well as the subaortic lymph nodes. So station 5, 6, 8, and 9, these are not accessible through the endobronchial picture. But if you take the same endobronchial ultrasound out and put it through the esophagus, you can go and look at the subaortic and paraesophageal. So except that, all the lymph nodes, the paratracheals, the subcarinars, the interbronchials, the hilar lymph nodes, you get them all through EBUS. It is usually performed under general anesthesia or conscious sedation, and the airway is secured. Usually people, they are starting, they secure the airway either by a laryngeal mask airway or ET tube, but we now do it just as we do a bronchoscopy, just putting a mouth guard, and then you can go in and you can start looking at the station. Start with examining the upper paratracheal lymph nodes, the lower paratracheal lymph nodes, 4R, 4L, station 7 lymph node, and then the 10R or the hilar lymph nodes, 10L or the left hilar lymph nodes, 11 is the interbronchial lower lymph nodes that you can examine. The patient is kept supine and you do it from the head end of the bed, performed in a bronchoscopy suite. This is how it looks. So you will have two pictures, picture in picture here. So this is the bronchoscopic picture and this is the endobronchial ultrasound picture that you can look at. And in real time, you can see your needle pierce the lymph node and move as you jab in and out. So you jab in and out 12 and 14 times while a pressure is applied on the needle upstairs, and that will give you your diagnosis. Use of Doppler demonstrates blood flow. Also, the sonographic pictures during endobronchial ultrasound have been found to be very useful because they can, the size, the shape, the echogenicity, whether it is homogeneous or heterogeneous, whether it is indistinct or distinct, and especially the lack of central hilar structure. An abnormal node will lose the central hilar structure. And in TB, lots of times coagulation necrosis sign, and in malignancy can be lost. So these are very useful things as you go and practice endobronchial ultrasound imaging. And if you compare it with the conventional TBNA, where it is a blind process, you can see that the yield with EBUS TBNA is a bold above 80%, whereas in conventional, in station 4R and 4L, you can have about 60 to 70% yield, but in 2R, 2L, the yield is less than 50%. So therefore, the yield is definitely better when it is guided. Similarly, in patients who are very sick, for diagnosis or even CT guided biopsy, if you like, of subcarinal nodes, some radiologists will tell you we can do it. But somebody who has this kind of a lung, would you really want any kind of a pneumothorax? No. So look at this. He has multiple lymph nodes here, and an EBUS is easily done under conscious sedation, not even general anesthesia. And in this gentleman's case, this was a small cell lung cancer. As you can see, there's a lymph nodal mass, and easily by going here, we got a sample and gave him a diagnosis. So EBUS has really changed practice of mediastinal lesions and transbronchial lesions in a very simple, minimally invasive way, outdoor procedure to diagnose as well as give less morbidity to the patient. And this is a very, very, very useful technique in our patients' diagnosis and especially staging of lung cancer and also other cancers. A lady with breast cancer comes with a breast lesion and a PET CT scan positive node, and it is assumed that she's stage 4. No, when we even a PET positive node, if you can be downstaged, if you do an EBUS and you actually find that the lymph node is actually granulomatous and not metastatic. So PET positive nodes can be downstaged by an EBUS. So wherever there is scope for curative intent, an EBUS for staging must be done. Let's come to the second case, of a 20-year-old fit and well guy with an abnormal chest X-ray during medical checkup during recruitment in the army. And his GP found a right-sided pleural effusion. He drained it, diagnosed it, and found it was an exudate with a high ADA. Practically, we are taught that high ADA means TB, a young chap, TB. But this was an astute GP, and he found a few atypical cells on cytology. So he started ATD, anti-tubercular drugs. But there was no improvement in the size of effusion, and he referred the patient to us. This time, there was again a massive effusion, so which was aspirated, but cytology was negative this time. The CT chest appeared slightly abnormal, so we planned for a medical thoracoscopy. And this is what the chest X-ray looked like. This is what the CT scan looked like. If you are able to look at the CT scan, the pleura seems to be irregular in places and thickened. And there is a collapse of the lung at the same time. So therefore, we planned a thoracoscopy. And thoracoscopy, I will talk about it in a bit. So a camera, so the patient is made to lie, does not eat for 6 hours, is fasted for 6 hours under local anesthesia, and giving the patient conscious sedation in the lateral position with the affected side up. You go in just as you would put a chest drain and put in a camera inside and look at the pleural space. And you can see that there were large chunks of tumor there. This patient would otherwise have got ATD. But because we were able to do thoracoscopy, these large pleural chunks of tumor were biopsied. As you can see, they are being biopsied, and it turned out to be a poorly differentiated malignant neoplasm favoring a pleuropulmonary blastoma. Now, pleuropulmonary blastoma is, as you know, HCG enriched tumor, and in younger people has a better prognosis if diagnosed early and chemotherapy started. So this histopathology was then sent for immunohistochemistry, which turned out to be metastatic germ cell tumor. We did an ultrasound of his testes, but there was no lesion there. Final diagnosis was burnt out extragonadal germ cell tumor. He received 4 cycles of chemotherapy plus radiotherapy and remained asymptomatic for a number of years. At the moment, he is lost to follow-up. I do not know how he is now. So what are the indications of pleuroscopy or thoracoscopy? Medical thoracoscopy, we have taken this out of the thoracic surgeon's hand. Undiagnosed unilateral pleural exudative pleural effusions, and therapeutically to pleurodesis and talc poudrage. In recurrent pneumothorax and superficial blebs, this is high level. This is not for people starting out on thoracoscopy. And very importantly, in patients who have loculated collections or loculated empyema thoracis, adhesiolysis and drainage can be done. The yield obviously is significantly increased because you are diagnosing under your vision of eye rather than doing a pleural biopsy, which is unguided. In malignancy, medical thoracoscopy gives 93 to 95% yield versus 43% in closed pleural biopsy. And in TB, there is 100% diagnosis versus 79% in Abraham's needle biopsy. When can you not do it? If there is a fused pleural space, if there is refractory cardiopulmonary status, if the patient is coagulopathic, if he is unable to tolerate a lateral decubitus, if he is in respiratory failure except in tension pneumothorax or massive pleural effusion. And relative contraindications are if multiloculated effusions look like empyema thoracis advanced stage, then that is the surgeon's domain, not ours, and if the patient is severely hypoxic. So the procedure, obviously, an informed consent is most important. The preparations as done in bronchoscopy, 6 hours fasting, lateral decubitus. By USG guidance, we look at the best site in the safe triangle. And after conscious sedation and vitals monitoring, we put in a trocar in place, take out maximum fluid that you can, and then the semi-rigid thoracoscope, which looks like a bronchoscope, but is rigid for the 2/3 part and is flexible in the last 1/3 part of it, is put in to examine. And then after examination, the abnormal areas, you take at least 5 to 7 good chunks of biopsy, and then put in a chest drain, which is a large size chest drain, to drain out rest of the fluid and the lung to come up, and suture it and come out just as you would do in an intercostal chest drain. It's a very safe procedure in trained hands, and overall complication rates are only to the tune of 1 to 5%, of which bleeding, infection, subcutaneous emphysema are the commonest. Sometimes if you drain out the fluid very quickly, re-expansion, pulmonary edema can happen. So keep furosemide to hand. And in some patients, there can be persistent air leak. Most patients can be diagnosed diagnosed and discharged within 48 hours of their procedure. So thoracoscopy and EBUS have had a major impact on us. But bronchoscopy, which is the key diagnostic technique which has been used for years and years and has helped us in guiding everything that we can, and has gone from the fiber optic scopes where we had to look inside the lung, inside the eyepiece, to video scopes, to specialized scopes for intubation and pediatric bronchoscopes. And the rigid bronchoscope made a return in a big way, and endobronchial ultrasound that we have worked. Let's go through what is it. So general utility is usually for diagnosis of infections, for cancer, parenchymal lung diseases, and therapeutically, lots of times in intensive care unit to clear out collapsed lungs during hemoptysis, etc., and for debulking of tumors. Removal of foreign bodies using specialized structures as foreign body forceps, catheters, wire baskets, etc., by flexible or rigid techniques has gradually gained a lot of momentum and helped many patients. And we have removed anything that you can think of, you have removed it. For example, foreign bodies can be anywhere from an inspissated mucus secretion to a peanut, to a coin, to a pin, to anything that you can think of, a chili that you could. So these are some examples of things that can be brought out by the gadgets that we talked about. Talking about whenever there is an endobronchial or airway lesion, then argon plasma coagulation, which is a poor man's laser versus laser bronchoscopy, can be done not only for endobronchial tumor ablation, tumor debulking, but also to maintain patency and then of the lumen, and then place a stent inside it for palliation's sake. And this is usually done in malignancy, which is restricted to endobronchial lesion, where the patient's hypoxia is worsening and the patient is very sick enough to undergo other procedures. Photodynamic therapy, which is used by oncologists for treating proximal airway lesions after traditional laser. If the patients cannot tolerate a routine resection of the lesion and there is multifocal tumors, which can be endobronchial with very poor lung function, photodynamic therapy can be used, where porphymer sodium is injected and then red laser is applied 1 to 3 days later, which then kills the tumor tissue. 3 days later, we just go in and then clean out and wash out. But remember, when photodynamic therapy is done, it can cause significant blackening of the skin. It is used only in specialized centers, but is useful in a subset of patients with proximal airway lesions where they are symptomatic and can't undergo other things. This is quite a favorite for many oncologists for brachytherapy of lesions, where insertion of radioactive pellets via hollow plastic tubes is done via bronchoscope. So our job is to put the radioactive pellets into the proximal airway lesion for local treatment of proximal airway lesions by radiotherapy later, by just putting in those radioactive pellets. And it requires radiation oncology and medical physicists to monitor the therapy of the patient. If necessary, it can be repeated. It is an adjunct to chemotherapy or external beam radiation in patients with proximal airway malignancies. So iridium pellets are taken with appropriate radiation safety. Then with lead protection, bronchoscopy is done and they are placed. And then post brachytherapy, follow-up is done to look at the amount of inflammation inside and the status of the lesion. Balloon dilatation, again, it is a very good invasive method for freeing up benign as well as malignant strictures. So proximal airways, where there has been, somebody has had TB as a child and has resulted in, bronchial stenosis, somebody who has had a tracheostomy and then post tracheostomy, they have had a tracheal stenosis. There you can do bronchial dilatation using these catheters. and has to be done under general anesthesia with appropriate caution for airway damage. For the same stenosis, malignant or benign, you can use silicone stents and self-expanding metal stents in malignancies to try and open up airways. This is again done using your simple bronchoscope. Rigid bronchoscopes are more useful than flexible bronchoscopes in doing this. In malignancies, it is usually a palliative procedure. The risks are that there can be dislocation or migration. Again, you will need your bronchoscope to locate them, make sure there is no infection happening, ensure that there is no plugging of that. So once you have put a stent in, that patient will require a number of bronchoscopies thereafter. Sometimes the stent tracheal obstruction secondary to malignancy. So we use the stent and then sometimes put a hitch stitch to try and keep it, because tracheal stents are most notorious for moving away from their areas, and simple metallic stents can be used in patients who have advanced malignancy and is being used as palliation. Coming to bronchial thermoplasty, this seems to be the talk of town. It has, what is it? It is an alternative therapy in severe asthma patients who are on maximal medical therapy but are having recurrent exacerbations. So it is only for a few subsets to be tried where the patient is still symptomatic despite maximal medical therapy. Radio frequency waves of microwave energy, which give heat, are used to gradually apply to the airway walls in a staged and a phased manner. The idea is to reduce smooth muscle mass so that obstruction becomes lesser. No clear randomized studies are still available, and it is still considered alternative, not experimental anymore, but considered alternative therapy, and should be given after due consideration that sometimes post-bronchial thermoplasty, the patient may have exacerbation of symptoms. It is an expensive procedure, so therefore needs to be done in the right sort of patients. Again, in advanced COPD patients where there is heterogeneous, severely reduced lung function, and there is heterogeneous COPD with upper lobe bulla involvement on one side, sometimes endobronchial lung volume reduction using endobronchial valves can be done. As you see, these are the valves which will open during expiration and close during inspiration, and they can be placed to try and reduce the size or the volume of the bulla so that the viable lung is not pressed by the non-viable enlarged bullous part much over a period of time. So the vent trial was done in 2010, published in New Journal of England Journal of Medicine. As you can see, the valve, the people who were chosen were about 321 patients were taken up between the age of 40 to 75 with upper lobe heterogeneous disease, FEV1 of 15 to 45, so severe COPD with volume. Look at the total lung capacity and the residual volume being 150. So they had hyper expanded lungs with unilateral upper lobe treatment was done, where the valves close during inspiration but open during expiration. Gradually over a period of time, try to suppress or make the affected part small. So they have one way a valve let air out of an overinflated segment of lung. Same general patient population that you would choose for lung volume reduction surgery, but not fit for major surgery. And by CT scan and PFT, you determine the location. The problem with them again is they can cause airway obstruction, distal pneumonia, infection, and the valves may migrate. It will be less to say that over a period of time in ICU management, bronchoscopy has played a major role in assistance with intubation in patients who have ankylosing spondylitis, who have problems with their spine, rheumatoid arthritis, torticollis, or kyphosis, in retrieving foreign bodies and using of the scope as a stillet to guide the endotracheal tube, and in the management of double lumen endotracheal tubes. In tracheostomy, the bronchoscopy assistance provides visualization into the airway, locates the landmarks, documents appropriate location of the tracheal tube, and helps eliminate injury to the membranous trachea. Today, above all, when lung transplant in the post-COVID era has been taking significant momentum, a success of lung transplant cannot be imagined without the flexible bronchoscope. And because not only you have to keep toileting and making sure that the new lungs are clean, You will also need to do intermittent transbronchial biopsies in these patients to make sure bronchiolitis obliterans is not developing, which is a sign of rejection. So bronchoscopy has gone leaps and bounds in trying to manage airways disease. As long as tobacco-induced lung diseases are there, these will continue to improve more and more. Let's talk about some of the invasive procedures which are life-saving, which is not done by a pulmonologist alone, but by our radiology or cardiology colleagues who help us in severe recurrent hemoptysis with usually long-standing extensive bronchiectasis patients. What does bronchial artery embolization do? We block the tortuous and enlarged bronchial artery where there is extensive bronchiectasis and it is not in the purview of a surgeon. There you can block the tortuous and enlarged bronchial arteries to stop massive hemoptysis, and it can sometimes be life-saving in massive hemoptysis. For example, in this patient who has severe cystic bronchiectasis and recurrent hemoptysis, their bronchial artery, as you can see, so many tortuous enlarged bronchial arteries are there, and post embolization you can see all of that has become lesser, so the chances of the patient being saved is very high. So bronchial artery embolization is available in most good centers where there is a good radiologist to help you out. The future has lots, including bioabsorbable stents, 3D printing of the lesion to customize the size of the stents that are needed, tracheal transplantation, stem cell therapy, and confocal bronchoscopy. So I could go on and on and on, but this was just a taster to tell you that interventional bronchoscopy or interventional pulmonology has gained leaps and bounds. But interventional pulmonology is more than just interventions. You have to be a good bronchoscopist to be an interventionalist, and interventions do not make you a better bronchoscopist. So you have to know where you have to do it. So because it has to be done, because it could be done, it does not mean that it has to be done. You should be justified in why the procedure is needed. You should be justified in why the patient needs the procedure. The patient's welfare always has to be paramount. We are losing it in today's world. We are only going and saying which procedures we did. We put it up on our social media showing what we did. But patient's welfare has to be more than self-gratification. When you're young, adrenal gland is pumping all the time. But you have to have a very sane head above your shoulders. Think about the patient and the patient's safety and the indication first. A good bronchoscopist is one who knows when not to perform the procedure. Anybody can do any procedure. You teach a monkey how to put on a hat, he'll do it every time. When not to put on a hat is what you need to teach them. Reducing health care cost is a civic responsibility. And in our country, where patients pay out of their pocket, you have to be sure when you're doing a procedure or offering them advice, it has to have a certain amount of responsibility coming from you. Just because it can be done, should it be done is the question you should ask yourself. And above all, it's a very exciting future ahead for pulmonology, especially interventional pulmonology. And there's lots more that can be discussed, but because of lack of time and because of the time that I have in hand, this is what I wanted to showcase and discuss with you all. Maybe we can talk about more things in the future. All the best. Thank you very much.